So we'll move on to the next talk, and the last talk of the session is by Dr. Reema Bansu. She is a professor at PGI Chandigarh, and she has several publications to her credit in uveitis. So Dr. Reema is going to be speaking to us on learning lessons in uveitis practice.
So, a very good evening to all of you once again, and I'm very thankful to my co-instructors for giving such wonderful talks and maintaining the time limit. So, I wanted to speak at the end after listening to all the talks in my session, and now I present a few points on the clinical clues on infectious versus non-infectious uveitis. So you may find some overlaps because these are the general teachings that we have, and we know when we target ophthalmologists who are seeing uvea patients also. So when we talk of inflammation versus infection, or an infection versus a non-infection, there are some basic primary differences. Like the infection, as we all know, is caused by invasion of the body tissues by a pathogen, and infection is not always present when there is inflammation. On the other hand, inflammation is the response of our body to any biological insult, and inflammation is always present when there is infection. So when we look at the uveitis signs of both infectious and non-infectious uveitis, we have certain signs which are common, like keratic precipitates, fibrinous anterior uveitis, or hypopyon, and retinal vasculitis. But there are some signs which are exclusively dedicated to infectious uveitis like retinitis, unless it's a Behçet's disease. But we all know how frequent we see retinitis in Behçet's. So it's a very rare sign to develop when there is Behçet's, because primarily Behçet's presents with hypopyon and vasculitis and choroiditis. So by and large, if you're seeing choroiditis, you should think of a non-infectious uveitis. So with this, I'll present few examples of hypopyon where we can differentiate between infectious and non-infectious. So we had this 43-year-old male who was a known case of cutaneous malignant melanoma, had undergone 3 cycles of chemotherapy, and came to us with a sudden loss of vision in both the eyes, left more than right. This is the clinical picture. His right eye vision was hand motions, left eye was only light perception. These look like two different patients, but they are the same, right and left eyes of the same patient. Now, the difference and the similarities in the two eyes are, you can see there is hypopyon in both the eyes, but the difference in the hypopyon in the right eye is it's a streak hypopyon. It is accompanied by fibrin in the pupillary area. The pupil is fairly well dilating. On the other hand, the left eye hypopyon is a straight, layered, thick hypopyon, very much white in color. We tried to dilate the pupil did not dilate. There is a lot of lid edema, partly ptosis, and a lot of chemosis. Now, are you dealing with the same etiology in both the eyes? Maybe yes, because it's the same patient. So this was quite a challenge for us. What are we dealing with? So let's see what we did with the right eye. When we dilated the right eye, we could not see much in the posterior segment. All that we saw was the glow. Now, this amount of fibrin does not necessarily allow only a glow to be seen. We expected much more clinical details. So since the patient was bilaterally almost blind, we offered a diagnostic and a therapeutic vitrectomy in the right eye, and we took up the patient for vitrectomy. This is 3 days post vitrectomy. We had put him on topical steroids. We did not start oral steroids because we were not sure what we are dealing with. So now you can see the fibrin is gone, hypopyon is gone, primarily because the topical steroids were there, and also partly because the vitrectomy was done and we had debulked the vitreous. We started gradually to see the fundus, and this is the post-op follow-up where we could hazily see the fundus, and the media was kind of grade 3, and on inferior down gaze we could see these exudates. So this was an endophthalmitis in the right eye, and endogenous endophthalmitis because he was post chemotherapy, so probably in immunosuppressed patient who developed endogenous endophthalmitis. So the right eye was doing well, and we did not do anything in the left eye. We did not touch the left eye, and this we told the patient that we are not going to do anything with your left eye because we want to know something from your right eye biopsy, what we are dealing with. So by the time we had some response in the right eye, maybe a week or 10 days later, the left eye chemosis had gone down, the hypopion had disappeared. Only thing that we did was we started him on IV antibiotics because we wanted to take care of the chemosis and the proptosis. We were not sure whether it's orbital cellulitis. So this was the response, and you can see the left eye has turned very soon into a blind eye. We got the PET CT of this patient because we wanted to know what's happening. So the PET CT revealed there was avid intake in the cutaneous thickening in the liver and the lung lesions and in the left choroid. So this was suggestive of a metastatic disease. So the left eye, if you go back to the picture, the hypopion was basically because of the metastasis in the left eye, the chemosis, probably it was everything in the orbit and the choroid. So this was the course of the left eye. And the right eye subsequently developed retinal detachment, which we managed to settle with oil tamponade and a revitrectomy. So this was how he presented with at the initial presentation, and this is how he became at the follow-up. We lost the left eye, but we could restore the right eye. Now you can see the pupil has dilated well, and he had ambulatory vision in the right eye. So this was an infection versus non-infection in the same patient. The clinical clues were different. We had chemosis. We had a very white hypopion, which is, if you have listened to the previous talks and the previous sessions, you have this white hypopion. It's pointing towards a masquerade. Now, these are three different patients, different phenotypes, but if you have to define, you have a choroidal granuloma on the first fundus photo, you have again choroidal granulomas in the second photo, and another lesion in the third. So just do the first non-invasive imaging, and here we have the OCTs, which give us enough clues. So we are dealing with a choroidal granuloma in the first case, may be tubercular because of the nature of the large bump of the RPE, subretinal fluid and fibrin, intense exudative response, which is very characteristic of a tubercular choroidal granuloma. The second one is also a granuloma, but I would not call it tubercular because these granulomas are deep in the stroma. They do not produce exudation. They do not push the RPE, and they are very much located within the stroma of the choroid, as seen by this arrow. So most of the times they are pointing towards the sarcoid granulomas. Of course, you would need investigations for corroborative evidence, but these are just the clinical clues I'm talking about. And the third one, many of us know, it's retinitis. OCT is to confirm the location of this lesion. You can see a lot of vitreous cells. You can see the full thickness retina being involved, also along with the underlying choroid being partly involved. Now you have the one on the left, you have these tongue-shaped peripheral lesions of retinitis. We need to look at these patients from the point of view of acute retinal necrosis. Another patient on the second picture on the right is another patient again marked by the arrow. A lot of vitritis, vitreous membranes, and you have these lesions in the periphery. So whenever you have these patients presenting to you with a lot of vitritis or a lot of inflammation in the anterior and posterior segment, many of them have panuveitis. So do not ignore the periphery because there is where you get the clue. And rather than labeling these patients of panuveitis and intense vitritis, it's actually an acute retinal necrosis. So a look at the periphery will tell you there is a large tongue-shaped retinitis lesion. Very characteristic. I think we don't need any investigations here. This phenotype is very suggestive of a progressive outer retinal necrosis. And then, we take the history, whether the patient is a post-transplant or an immunosuppressed patient or an HIV positive. So these were the cases of intense widespread retinitis. We do see cases where you just have focal retinitis, and these are more challenging than the widespread peripheral retinitis. I'll tell you why. So these are again two different patients, but absolutely similar clinical picture. The one on the left, you can see there is a lot of vitritis. The arrow points towards a focal retinitis lesion. Similarly, in the second frame is of the right eye of another patient. You have vitritis and there is a focal retinitis right at the fovea. Now, the patient presented with decreased vision, floaters because of so much of vitreous inflammation. Now, when we do the OCT through this focal retinitis lesion, and I would not do an FFA before I do the OCT because I want to know the nature of the lesion. So when we do the OCT on the on the left side, you see the lesion is involving full thickness retina. It's a horizontal involvement of the retina. The underlying choroid is relatively spared. You have a lot of vitritis, of course, that's there in the other eye also. So this was actually after eliciting the history, doing the investigations and doing the fluorescein, turned out to be a patient of Behçet's disease. And the other one where you have this large peak, this is a typical rain cloud sign that we see in fungal endophthalmitis. So this was a fungal endogenous endophthalmitis. Now, if you remove these OCT pictures, the clinical pictures are very much similar, but you need to differentiate. One is non-infectious and the other is infectious. So sometimes your imaging only gives you the clue and you don't have to do very thorough investigations. Two different patients, similar looking hypopyon, pupil dilating very well in both the patients. The only difference is there is a bit of pigment on the interior lens surface on the second eye. Now, when we dilate, it's important to see why I lay stress on posterior synecdoche is because if you have intense posterior synecdoche in a patient with hypopyon, that means probably we are dealing with acute interior uveitis. That is where you need to get an HLA-B27. But if you have these kind of fully dilating pupil, not showing any posterior synecdoche, but hypopyon, try to look at the fundus. If you're able to see just the glow, no details, think of endogenous endophthalmitis. If you're able to see the fundus, go ahead with the fluorescein angiography and you see this Behçet's vasculitis. So again, infectious versus non-infectious. So one, we are dealing with endogenous endophthalmitis. The other, we are dealing with Behçet's uveitis, both presenting with hypopyon uveitis. So vasculitis also, we have certain clues we may have or we may not have. So frosted branch angiitis typically known to be occurring Behçet's disease, but of now lately, as Manisha also showed you, we are seeing this more in tubercular etiology also. So this was again our patient who presented later in left eye with frosted branch, and he had already undergone treatment and laser photocoagulation in the fellow eye for TB vasculitis. This similar looking young male presenting with frosted branch vasculitis, when we investigated him, took his history, he turned out to be syphilis positive. So to summarize, infectious versus non-infectious uveitis, the clinical clues are most crucial, followed by our clinical examination and then history. So identify the clinical clues, pick them up in your clinic itself, and then work up the patient. We need to act aggressively but cautiously for the infectious cause because if we are in a hurry and diagnose a non-infectious cause, we end up giving steroids, which may be a major blunder for an infectious cause.